So we're going to have a good session this next session. It is fair to say that robotic surgery has probably created more interest than any topic in the last 5 years in knee replacement, and it's also probably fair to say that it's created more controversy than any topic in the last 5 years in knee replacement, notwithstanding the alignment controversy, which is partly brought on by the fact that robots are available. So I'm going to introduce our panel and just ask everybody to introduce themselves, running down the list very quickly, and then we're going to get on with this session. I've got about 10 or 12 questions to ask the panelists about robotic surgery. Go ahead.
Hi, this is Vaibhav. I am from Mumbai.
Okay.
Yeah, Mahesh Kulkarni from Pune.
Rajesh Manyar from Mumbai.
Dr. Chandrasekhar from Bangalore.
Anup Jurani, passionate about kinematic alignment.
We know. We noticed that.
Alberto Carli from
I'm kind of scared, in fact, Anup, after that. Jesus, you look so serious up there. My God. I was like, oh, has he got my panel? Oh, hell, he is.
Sachin Tapasvi, Pune.
Amar Ranawat, HSS.
All right. Okay, we got a tremendous panel. We've got some good questions, and we're going to have some fun here. And if not, we'll serve the appropriate panelists a drink. We'll see how it goes. My disclosure is that I receive royalties from DePuy on some hip and knee products. So this is my first question to the panel. We all agree that there's a lot of interest in robotic surgery, but let me ask you, what's driving the increased interest and adoption of robots in knee replacement? Is it companies that are driving it because they want to sell them? Is it surgeons driving them because they want to sell something? Is it surgeons driving them because they think there'll be a real change in what they can do? Is it surgeons using it as a form of marketing? Give me your opinions. There's probably some others. Let's start with Amar.
Marketing.
Wow, that was a concise answer, and it might be true. Okay?
I think it's the quest of trying to find what works best and most consistent.
Okay, so Sachin, you think that it's a new tool that might let you do new things more consistently. Is that what you're going to say?
Please.
Okay,
Yeah.
fair enough.
Marketing and then achieving a consistent outcome.
Okay, so you think it's a little bit of both?
Giving us a lot of data points, especially on flexion kinematics, the initial deformity, and our ability to do alternate alignment more accurately with robotics.
Okay.
Switched over from navigation to robotics, so interest was purely not marketing for delivering the same result to each patient all the time.
So you want consistency?
Yeah.
Okay, Rajesh?
Consistency, the slightly two different things in USA, where the computer navigation was not so commonly used.
Yeah.
I think a lot of people are getting to it because of the correct alignment that computer can give, which is part of the computer navigation is part of the robotics. But everywhere else, I would think it is the consistency of what you want to achieve that is driving it.
Okay, fair enough. And is there any element of the ability to make minor tweaks that are hard to make with manual instruments?
Yes.
Yes, you think so? Okay.
I agree with everyone, marketing followed by consistency, but marketing is losing its ground because the city like Pune has become a robot neutral city. Everybody has one.
Yeah, once all the companies have one and once everybody's got one, then the marketing element goes away, right? Okay.
I think science, number one. I know I'm contrarian to everyone here.
Yeah.
Number one, science. Number two, art. Number three, commerce. When you have all three, thing wins, and it will win. And you shall see it 10 years later. Science, because it gives us ability.
It's going to win practically because everybody's got one. The question is, will it improve outcomes? But we'll get to that.
Yeah, so science, yes, because you will see, you have got the next questions. We'll tell how science addresses it. But I'll talk about the art. We are all craftsmen, but any tool that makes us better craftsmen is appreciated by all good craftsmen.
Fair enough.
Commerce, anything that drives up your volume will succeed. So all three, science, art, commerce.
All right. Well, we'll see about that. Okay, let's go to the next question. What are the main capabilities that a robot provides that manual instruments do not provide? Let's start on this end of the panel and brief, consistent questions.
Number one, fun. Number two, my ability to deliver what is best for the patient with less soft tissue release, with the titrated alignment philosophy, which I call intelligent alignment, to solve the problem of the last session. So ability to deliver an intelligent alignment, ability to reduce soft tissue release, have more fun in OR, more consistent, less blood loss, and of course, more patient volume.
I see you're a believer. Okay.
I think it basically an experienced surgeon and a young surgeon with a few number of robotics I think a younger surgeon will bring the alignment faster, and he will learn the alignment very much faster.
So you
He
think
will
that for
shorten the gap.
so the inexperienced surgeon will get to the level of an experienced surgeon quicker because they've got a better tool. Is that your argument?
Exactly.
Fair enough. Rajesh?
I think the consistency in getting the alignment and tweaking that alignment, that is the key reason I think this, that is what it
So
gives
the
you.
ability to fine-tune something that was hard to fine-tune before in a
Exactly.
scientific way, is that your point?
That's right. And the second is to know
I have to
before-
interpret sometimes.
So that's for the alignment, and for the balance, it gives you an idea beforehand, before you make your cuts. Just after making a tibial cut, you put your tensioner and take your balance graph, and it gives you an idea what is going to happen.
So you can do something before you commit, is that your point?
Exactly, and at each step, you can do that after a anterior or posterior cut of the femur. Again,
Okay.
you can check your balance and you can tweak, and all the recuts that you can do with Robo is just super. You can go through that very quickly without taking much time.
Okay, fair enough.
Adding down to the same points what Rajesh and Vaibhav said, dynamic joint balancing. You can start as a mechanical guy and switch out to a functional guy on tables. You have all the options. Tweaking those 2-degree varas and femur and tibia is not possible on conventional instruments.
Yeah, it's hard to do it.
Proof at every calibration at 0 to 120 degree. So that's the reason why I switched out robots.
Fair enough. Anup?
Unquestionably a great asset for uni-compartmentals, no question
We're going
about
to talk about the unis eventually, yep.
So for the sagittal plane, its manual instruments don't tell us anything about the flexion of the femoral component. So the flexion of the
much
femoral
anyway,
component and the slope of the tibia is far more accurate with robotics.
Fair enough. Alberto?
Image-based robotics helps you preoperatively plan. That's the main advantage. Otherwise, it's another more complicated way of verifying your alignment. That's the only benefit I can see.
Okay.
So I think the capability is preoperative registration, planning, post-operative confirmation that you've got to the correct place. And I think the second capability is not needing to open up the intermediary canal on the femoral side.
Okay. Do you think that matters really?
It doesn't really matter, but that's the only capability.
Okay, fair enough. Amar?
I don't think there's any advantages.
Okay. We know where you stand. I know how you're going to answer a few of the other questions later. That's fine. Thorsten, anything to add?
I mean, it's nothing, but probably better intraoperative control what you are doing.
Okay, fair enough. Who wants to take this? We don't have to have everybody answer this. I'm just going to ask one or two people. Rajesh, can you give us a quick rundown? What are the main differences between robotic systems? Let's not have a marketing talk. Just give us scientifically what are the main differences. 2 or 3 points for the audience.
Burr versus saw.
Burr versus saw. Okay, fair enough.
That is the most important difference.
Okay.
The second is whether the bulky instrument is attached to your table or is it separate and giving you room.
So the exact configuration of the robot itself. Fair enough.
Otherwise, most of the system will give you exactly the same, the alignment, the balance, the ability to tweak all the three, both the components.
Let me ask about 2 other ones. What about haptic boundaries?
So
Some
yeah,
have them,
haptic
some do not.
boundaries, so autonomous versus semi-active.
You can ask whether that's good or bad, but some people, yeah, there's
And
both.
image-based versus imageless.
Image-based versus imageless, fair enough. Anybody have anything else to add? I think those are the main ones, and they're the ones to be aware of. We're not going to say that one's better than the other, and there's obviously competition between different companies that provide different assets, but they are different. All right, so let's start with the next question. Which types of cases might benefit most from robot use? So Thorsten, I don't think you're using the robot, but if you think about it in your hospital, you're in charge of many, many surgeons. There's thousands of cases done a year. Which cases do you think might really benefit from this technology, if any?
If there are cases, and I think, complex deformities.
Okay? So you think it's going to be the complex cases, not the simple ones that...
Complex
be okay
cases,
otherwise?
complex deformities and several levels, so.
Fair enough. Amar?
I mean, I don't think you need it for any case.
Okay.
So yeah, that's.
So you're not a believer, we know that. Okay?
So I think it's 2 sides of the spectrum. It's most beneficial for those very mild to minor deformities where you really don't need too much of a correction, and for those who have an extra-articular deformity and retained hardware.
So you think it's the 2 edges?
Absolutely.
The patients that are more or less undeformed that you want to just tweak and dial in just that last half degree, and then the rest of the ones with a huge deformity where you want some help.
Absolutely.
Okay, Alberto?
I would tend to believe that image-based Robotics is probably the most useful for me, so that would be a complex case where I need to get a CT scan for preoperative planning. That's what I find this would be the most
The
useful.
sort of situation where standard instruments are kind of hard to use and you're doing a lot of Kentucky windage. Yep, Anoop?
But you need to use it every day to be able to use it in a complex case. So do one case every day, 2 cases every day for you to be able to do that complex case.
Okay, so if you're not doing it all the time in easy ones, then you can't do it in hard ones. Is that your argument?
That's right.
Might be true, okay.
Image-based robots, so definitely complex primaries helps.
You like it in complex
Also, in the moderate OA, if you are planning for a kinematic, it helps. So doing every day, one or the other philosophy helps to get
So
a
if you have a kinematic philosophy, it might help you more than if you're a mechanical alignment person. Is that right? Amar's going to argue about something, I think.
No, just, if you're going to operate every day, you definitely don't need a robot.
Okay, fair enough. Rajesh?
I think every case is going to benefit with the robo because of the computer navigation giving you the alignment. However,
You
I
like,
would say,
you like the precision of it.
yes, I like the precision of that. And the only time where, in a mildly deformed case with not much of a remodeling of the tibia or the femur, you are not likely to be in an outlier zone with the conventional instrument. So that's okay.
If you're an experienced surgeon, right? Fair enough, okay?
If you believe in alternate alignment philosophy, then each case is considered to be a case for
Yeah, I
robotics.
agree with that. If you're going to try to start deviating much from mechanical alignment, then it probably helps you more.
You know me, I'm a believer, so I think it benefits all cases, but primarily extra-articular deformities, those with retained hardwares, being at the cost of being dogmatic, all unis, and all those where you are choosing to have an alternate alignment philosophy or leaving constitutional varas.
Okay, so it's interesting. There was actually more consensus there than I thought there'd be, and the big consensus was around tough cases with big deformities, especially extra-articular deformities, people that are using alternate alignment philosophies on a routine basis, and then we'll get to the uni question, but that's probably true too. Okay, under what circumstances is it worth learning robotic methods? So there's a lot of surgeons out here. Some of them are doing, I would guess, 10 total knees a year. Some are doing 500 total knees a year. Some are at the start of their learning curve. Some are well into it. When is it the right time to think about it, or is there always a right time to think about it? Thorsten, do you want to say anything about that? You control a lot of surgeons.
I mean, it's always worthwhile to learn something.
Okay.
And I think it's good to learn it and at least to judge about it.
Okay, so if you're going to talk about it, you got to try it?
Exactly.
Okay, Amar?
I think we have 9 Mako robots at HSS, and I don't know how many other systems that we have. But when we asked our fellows a couple years ago on their exit interview, they all basically said that their experience involves too many robots.
Yeah, most of the fellows in the US right now are looking for more experience with manual instruments because they're afraid they aren't going to know how to do them pretty soon. Sachin?
Yeah, I think, it's definitely a worthwhile exercise to learn what the robotic technique or technology will be, because believe me, in about a decade of time, we'll have something which is more AI based, and probably you don't want to be left out when the whole world is progressing.
Yeah,
So
there's no doubt that it's going to be a big part of practice, right? So if it's going to be a big part of practice from the practical standpoint, it's helpful to know something about it. Alberto?
Nothing else to add, I agree.
Okay, fair enough. Anoop?
Nothing.
Nothing more?
An youngster, if he wants to be a robotic surgeon, I would tell him to be a good conventional surgeon for initial few years,
Yeah.
train them in navigation, and then proceed over to the
Yeah, I
robotics.
think that's super important.
Don't jump into the robotics straight away.
I don't have a question about that in here, but the whole education element of robotics is a little bit concerning, right? And it gets to the points that were made earlier by Amar, that with the pervasiveness of robotic surgery becoming very, very common in some countries, it's going to become common here. The concern is, will surgeons ever learn to do a good manual instrumented implant? We'll get to that point in a minute about your bailouts when problems occur. Rajesh?
I think the basic training is the most important part,
Yeah.
the conventional total knee arthroplasty. However, if I think a resident has seen a number of robotic surgery or the navigated surgery to begin with, he can jump into that because it's a different aspect. It's alignment. And I think going back to manual instrument shouldn't be a difficult task anyway.
Except they have to know how to use a saw.
Definitely, I would say for a young surgeon, learning manual surgery is utmost importance.
Yeah.
But for an arthroplasty surgeon, you cannot not do robotics.
Okay?
I'll quote Alvin Toffler here. The ability to learn, unlearn, and relearn is a superpower. So they talked about younger generation. I think the older generation should learn it.
Future
They'll bring
Shock,
much more
Future
value.
Shock by Alvin Toffler. That's who you're good at quoting, right?
They'll bring much more power to the robotics if the older generation learn.
Fair enough.
Experience and technology within combination.
So all of you, virtually all of you said that there's some value in learning robotic techniques in the coming decade. How should somebody do it? Should they just go to a course and learn it in a half an hour or 45 minutes, or do they need to go visit people, work on it, practice, use cadavers? What's the right way to learn it? Let me just ask a couple people who've gone through it. Rajesh, I'm going to ask you first.
I think, and this is the most important question, because the learning curve any procedure has. With the robotic, you have a chance to reduce your learning curve by 80% even before starting the operation. And that's exactly what you pointed out too, that you should understand it, learn on the sawbones, then maybe do it on the cadaver. Just attending the meeting is probably not going to be enough. In fact, it's going to be confusing. It's only when you start using it, you know what steps to take. And so I think you need to go through these phases. You need to see someone, understand the concept, and go through training.
So can I ask you your opinion on that topic?
So visit.
Okay. Go to surgeons that are doing it.
That's right.
Is going to a company course enough or not?
Sorry?
Is going to a course run by a company enough or not?
No, that's not enough. You need to go to the OR, talk to the surgeon, sit and discuss the planning, see a few cases, and then start doing.
For young surgeons, they can do fellowship programs where the robotic programs are done regularly. For the guys who are already having good numbers, they can do visitation, senior one-to-one visitation, and learn from them.
I think
That's the way to-
that's well said. I mean, people in training are going to get the training and training. It's people that are already out of training that are thinking about a new technology. That's the group that's going to have the toughest time, I would think. Sachin, anything else to add?
Yeah, I think so. I mean, I completely agree with you. Since I do a lot of sports preservation and replacement as well, I've learned a lot of new techniques, but learning robotics and trying to master that has been the toughest skill set of them all.
It's been tough.
It's
not
been
easy. Why has it been tough? I'm interested that you said that.
So the reason being is that when you're good at conventional surgery, or so-called you feel that you're good at conventional surgery, suddenly you have all these numbers that are thrown into you. You have all these new alignment techniques that are thrown into you.
And you suddenly got a lot of data you never had before, right?
Exactly. And then suddenly you start feeling, am I making the right move? Am I doing the right thing? And then you get too engrossed in looking at the screen, and then you start forgetting to look at the actual knee per se, which is where you're trying to drift away, and you need to really refocus to try and bring yourself back on track, to understand that, you know, it's actually the clinical field that matters more, and you need to actually learn to disregard some of the numbers.
Yeah, it's not a video game.
At you.
So that was really well said. I hope all of you heard it. That was terrific, Sachin. Thank you. Okay, now here's my next question for you. What are the main technical problems that you as a robotic surgeon have already encountered or are afraid you may encounter using a robot? Let's start at this end of the panel. And let's have some honesty here.
No, I'll be very honest. So there are problems with both techniques and technology. So if you talk about techniques, again, getting adapted to all those numbers, as Sachin said, it can be a bit mind-boggling. The ability to manage the OR in terms of visibility of tracker can be an issue. Of course, we know about pin track issues, which is a given, but sometimes even the robotic arms, just like any software, can get jammed. So the ability and the confidence to switch on from robotic to mechanical, again, is an important thing. And you made a very valid point that you must learn both. So if your auto mode driving fails, you should be able to take care of the steering yourself.
Yeah, and I'll just go one step further, that you need to know when things are going bad with the robot, right? So that's the other element, right? So there's one, to know how to fix it, but there's also the element to recognize it. And we've already seen some problems in North America where surgeons blindly followed the robot after the arrays got loose or something like that and did some really stupid bad things, I'll just tell you. Yes, sir.
As you just mentioned, I think loosening of the trackers as well as losing your checkpoints.
So how do you make sure, how do you recognize that problem's happening and how do you look out for it and avoid making a catastrophic mistake? Because if the tracker's loose, I'm sure the audience understands, you can suddenly be way, way off, not a little off, way off.
Always watch what you're doing. You need to have the experience to understand that the robot is not doing the right thing.
So if you're cutting 2 centimeters off the distal femur, something's wrong.
Yeah, and also there are enough alarms in the robotic system that I use, which will allow me, which will basically tell me that something is off. It wouldn't allow me to progress, especially.
Yeah, you hope so, but remember what happened with the 737 MAX, right?
Exactly.
The alarms weren't always right. Okay,
So I think the pin loosening, and I think that's why I don't bypass the step of checking the point. And that's a very important.
Okay?
The second thing is that you always have to go back and forth. When you start using this technology, you may have to go back to cadaver or to the Sorbonne and understand something that you did
Okay.
not see first time. So it's going to be back and forth to the
Okay, that's
Sorbonne.
an iterative learning process. Great.
And also going to a surgeon and asking him what happens when such a thing happens.
Yeah, so you definitely want to know that before you get into the operating room by yourself, right?
Exactly, but so even after you started doing it, you might have to do it.
Yeah.
But if you remain with it, you're going to get there.
Okay.
It's not. It looks difficult to begin with, all these numbers, etc. But once you start, I think you need to sit and break it down. What is important first? Which numbers are important? Only follow those.
Yeah, be careful not to get overwhelmed by the data.
Patience when you're venturing into robots, because you have to just let your ego down and then say that I am not going to finish this case in 20-25 cases. Initially it takes time. And then
So a little patience with yourself.
patience, and then also establishing the team in the OR is very, very important.
point.
For high volume surgeons, it's very difficult for him to sit, calibrate on the table. So you need to have a strong team who will take over, moving the robots within the system, having patience. And third, most important is pin loosening, third. And the fourth is whatever the robot shows, the numbers is what the surgeon has on the brain. So ultimately, whatever you feed to the robot, it does what you feed. So most of the times it's a bit tough initially, but don't believe the numbers if you feel that you are complementing your work yourself.
Fair enough. Anoop?
Measure the cuts always, and keep checking and verifying that you're right. If you're way off, then something is wrong. Then you need to re-register.
So that's a really good point. Double check based on common sense and your knowledge of what things should look like, right? Alberto?
So as my experience with image-based robotics, definitely registration can be a nightmare, especially in the hip with bad bone and loose arrays. You can
Be careful about the registration.
extremely careful. And the knee maybe not so much, but the hip especially. And then obviously soft tissue assessment. When you go ahead and correct your varus deformity when you're doing a uni and you're using an image-based thing like a Mako hip, for example, and you correct the knee to neutral and then you flex that knee, once you get past 45 degrees, the entire knee becomes disconnected. I've seen expert surgeons in my institution who do this day in and day out, and I ask them to do that tracking again, and then do it again, and do it again, and on 4 times they got 4 completely different waveforms. And the rep every time said, "Looks great, doc." And that information is what the robot uses. So I don't think the robot really understands soft tissue data, and we have no idea what we're doing when it comes to letting the robot trust us with that. So that's my main
So
concern.
we're a little on the early days on that side of things, not as far along as some people might like to pretend. Sachin?
Yeah, I think I really echo Alberto's statement there. That exactly is the main problem that we really face.
Okay, fair enough. I'm not going to ask the last two because they're not doing robotic surgery routinely. Okay, what's your bailout and how do you identify and prepare for the time the robot's wrong? Sachin, let me ask you to start with that. Let's make these kind of quick because we have a few more questions to get to.
So I think the bailout here is to have all the conventional instrumentary ready to have a backup.
So
because
you got to have them in the operating room and you got to have them
absolutely,
available.
you have to have all the instruments open
100%
on
of
the
the time.
table. Yeah, 100% of the time.
So this idea that the robot suddenly gets rid of all those instruments is not quite right.
Absolutely not.
Okay?
Yeah.
Fair enough.
So that's
Albert?
one, and you also need a higher constraint backup, just in case, you've done some crazy thing with your robot. You need to put a rod up or down the stem, you need to put a stem on, then I think that needs to be ready as well.
That scares me. So bring a hinge every time you use a robot? I don't know. Okay, Alberto?
Agree with everything Sachin said, and then for a robotic uni, once you've already made the cuts and you realize something's wrong, there is no bailout. So you're in real trouble there.
Okay, we're going to talk about that in a minute. Anoop, anything else to add? No.
Conventional standby always.
Always ready.
So conventionally standby, but say you're doing 3 or 4 cases, you don't open those.
You have them sitting there ready to open. Yeah, fair enough.
Second thing is we need to ask question that how many times did you actually need to bail out? In the navigation that I can't remember in the last 10 years that I've needed to use a conventional.
Fair enough. So it's not a common event, but if it happens, you got to always be ready, right? Anything else to add, guys? No. Yes, Amar.
But you never ask what's your bailout when your conventional instruments don't work, right? My point being, if you really think of yourself as a knee surgeon, you should be able to do the knee placement without any instruments, just a saw, right? If you can do a reasonably good job, it doesn't have to be perfect, a reasonably good job with just a saw, then you're a knee surgeon. Then you know fundamentally what you're doing.
I don't disagree with you, but I promise you that if you ask everybody in this room to do a knee replacement with just a saw, we would see some very interesting x-rays. We're going to get to questions later. Okay, my next question is, how do you and your hospital make the economics of using a robot work? They're expensive. Let's start with a guy who's got to run a hospital, Thorsten.
So in Germany, everything is extremely cheap. So our benefit to put
Except cars.
put in a knee replacement is about 800 euro per case for the hospital. If I use a robot, I pay about 900 euro for everything.
Okay.
For the robot, for the stuff around the robot. So the hospital in Germany actually doesn't earn money by using a robot. You lose money. That's the reason why the robots in Germany are not really frequently used.
Do people like to use them because they get the market share, so they get patients into the office?
The only reason is to attract patients, to be modern.
Okay,
and,
yeah,
that's
right,
it.
to see, like, okay. Sachin, how about you?
So I think, there are a couple of various commercial models.
Yeah.
How robots work in India.
Yeah.
And I don't think this is the forum to discuss those commercial models.
Yeah.
But typically, if I put a split in the Indian patient database that we have, there are patients who are self-paying and those who are insured.
Yeah.
Currently, about 90% of insurances do not allow robotic joint replacement surgery. So the patient has to pay out of pocket.
Yeah.
And the note has to go in the official case file that you've done a conventional knee replacement. Otherwise, they don't get reimbursed for the conventional 100%.
In India, is it common for the companies to give you the robot, assuming that you'll do a certain volume of their knee replacements, or not?
I think that's classified.
Really? Because I can tell you categorically that's happening in the United States, and that's not classified information.
I guess it does with some companies.
Yeah.
The ones which I use, probably, at least I don't work on that model.
Okay, fair enough. Other comments?
To be fair, they give away a robot to one guy in town and make the other guy buy it. That's how they do it.
Well, if they're giving it away, you can be guaranteed that they're doing it for a reason, and the reason is they want to sell you the implants at a high price because you're now locked into using the implants. So there's no free lunch, right? Rajesh, any other comments? Comments from the art, science, religion side of things?
Good. Yeah, so both art and science. So coming to the point, marketing alone without good art and science will fail. Time immemorial has shown that a product only being sold for marketing will not work.
Okay, fair
It has
enough.
to be backed by art and science, and that will make the economy work.
The length of stay can, length of stay can be reduced with the robotic surgeries. Length of stay, one, we can save the cost there, but not the medical
The
comorbidities
data on that
also.
are a little soft, right?
Also, the instruments which we open on the table, we don't
Okay.
have to open all the instruments. That is another economical
Okay.
usage. And then probably the happy patients which get the happy patients.
There are, well, that might be true. Okay, so here's the 10 million lock question. Does using a robot change the outcomes of total knee arthroplasty? And if you say yes, is it usually or occasionally? Quick answer, starting with Thorsten.
If you are believing the non-biased literature
Yeah.
and the reviews, the answer is no.
Okay, Amar?
No.
No.
Generally, no.
Usually, yes.
Okay. I knew we'd get some interesting answers here.
6 months, definitely yes. We do a lot of bilaterals in India. The pain quotients, if they are less, it's definitely less. If I have to get my tooth extracted and there's a technology which gives less pain, I will go for that technology. So definitely yes. The first 6 months, long term, yes, to be seen.
Okay.
The answer is yes and always. In two terms, it improves. The one is the number of patients that I would say, wow, who's got the great result,
Okay.
changed from 70% to 90%.
Are you sure that's not because you told them a robot's great and they're extremely happy and they've got a
I
placebo
think-
effect?
I'm saying this from my computer navigation time as well.
Okay.
When there was no extra charge to the patient for computer navigation, it's just that I wanted to use computer navigation and I used. They didn't know. I think that the consistency in the results changed once you have some alignment guidance.
Okay.
And also probably
Okay.
for each individual patient.
I'm going to take the moderator's prerogative. Give us an extra 5 to 7 minutes because we will have plenty of time for discussion because there's 25 minutes for questions.
Definitely enough papers to suggest that the short-term outcome is definitely better. We don't know the long-term outcome.
At least in a few patients, right? Yeah, fair enough.
Usually, we've been hardwired to talk only about survivorship and forgotten joint score.
Okay.
There's so much more to outcomes that's never measured, never accounted for, and so much personal variation.
Okay.
Usually, yes.
Okay, you guys didn't see it, but I flipped the switch here and added unicompartmental arthroplasty. So
Before that, I wanted to ask one question.
it's got to be fast.
There is a question here whether will it improve the result, but can being more accurate deteriorate the result? No, there's not going to be a problem by using something which is giving you better alignment and better ability to balance.
Fair enough. I think the downside's probably fairly low. There's pin track problems. There's a few things, but not too many, probably, right? Okay, how about for unis? How many of you believe that there's a value for using a robot in a uni that exceeds that in a total knee? Most of you. And that's just because the uni is a little bit harder instrumentation-wise without a robot. Would that be the main reason? Anybody disagree with that, Alberto?
I would just say alignment. It keeps me from overcorrecting the patient. That is the single reason why I do
Yeah,
it.
and unis are just a little tougher to make sure you get that right every time. Amar?
But again, it really comes, it is tougher, I'll grant you that, but it's really a volume-driven thing, right? People who do a lot of unis do great jobs, and they've done them with conventional instruments for many, many years.
Yeah.
So it's the problem with unis is you don't do that many of them, and so therefore it helps to have a better tool.
I think I'd agree with that, and I think it's also true that the same effect is probably the case in total knees. If you're a supremely skilled and experienced surgeon, the value of the robot to you in terms of changing your outcome is going to be less, let's face it.
Yeah.
I mean, it's just, because you're very consistent without the robot, right? Okay, here's my last question for you. What are your watch-outs to a surgeon about to start using a robot in total knee replacement? We're going to start right here.
So team, technique, and technology. So team, I think it's very important to have a supportive team.
Okay?
First few
Does that mean the rep, or does that mean something better than that?
Everything. The frustration comes from, the first few cases, comes from inability of trackers to be seen by the camera.
Yeah.
Spend more times. Or inability for your staff, because it's a space occupying lesion in the operating room.
Yeah, it's big,
So
some
team.
of them.
Okay, then the technique is, of course, don't put yourself in a time pressure. It's going to take first 20 cases, you're going to spend more time, be patient.
Okay, that's a great comment.
Backups.
Yep.
The peace of mind is most important. So backup. So if you have all three, you will learn one case at a time.
That was terrific. Thanks. Those were really good. Yep.
I think obviously sawbone workshops, cadaveric workshops, surgeon visitation, and proctors come into your theater for the first few cases. But I think most of the robots are married to a system, so you need to sit down and understand that implant system thoroughly so that you can actually have some bailout options with the standard instrument.
It doesn't make sense to be learning a robot and a new implant system at the same time, right? That's crazy. That's completely crazy. Rajesh?
I think exactly the same, that you should be able to do it on the same implant that you are really used to. That is one. The second is that your team needs to know what exactly is happening in the OR. You need to train.
So not only do you have to train, your team has to train.
First you train yourself, then the team, and pick very simple cases to begin with. In
Okay.
terms of the deformity, in terms of the flexion.
So don't
stiffness,
don't
etc.
try it on your biggest extra-articular deformity the first time.
Patients to learn, patients to keep the learning,
Yep.
and believing what you are doing. And it might be irritating first few cases with the time, but I've always told patients is the most important key, and making your team believe that this is better, and then works out better for the patient.
Okay, thank you. Anup?
Beware of osteoporotic patients,
Okay,
especially
that's a very good watch out because of the pin track issue, right?
pin track fractures, yeah.
Yeah, and the fact that you can have the tracker loosen a little more easily in those patients too,
That's
right?
right. So osteomalacia.
Don't start with those patients.
Don't start with those patients. Yeah.
Fantastic.
I would just say if you're beginning to introduce robotics into your practice, to take it as if you're starting a new implant system. Why are you doing this? Get some baseline understandings of what problem clinically you're addressing. I have difficulty balancing knees. I struggle with complex cases. I'm inefficient in the operating room. What is the actual problem that you're having?
I don't have enough patients coming into the office.
Or I'm manipulating 1 in 6 patients. Understand what your metrics are, and then when you introduce this new thing, watch your metrics. If your cases are twice as long, patients stay 3 times longer in the hospital, there's a problem.
Okay?
Yeah, I think.
Sachin, you get the last word.
Okay, I think one of the things that I'd like to add is that for the first few cases, have an extra pair of trained eyes in the room who's not scrubbed up, who's watching over your shoulder, because you're going to be engrossed watching the knee, watching the screen.
That's a good one.
Yeah.
So don't get caught with the idea that you're sort of distracted by all the technology. You have somebody else there making sure it all makes sense. Yeah, Amar.
I do have a watch out. Watch out, it might not be as fun as you think it is. I have a colleague who, we operate on the same days, and we come out of the rooms around the same time, and every time he comes out, he's drenched in sweat. He's using the robot all day long. Just saying.
Maybe he just doesn't like to pay for a fitness center, I don't know.